While reviewing a contract between you and another healthcare provider might not be so gripping, it's got to be done. And why? Because there can be landmines placed all over them. Now, the introduction that I just read might sound similar to a different episode we did with the same guest a few months back. This is very, very different. That was about various vendor arrangements, and those have their landmines. But this episode today is very different, um, very unique. My guest today is a healthcare attorney. It's the same guest as last time, too. He helps his clients negotiate fair agreements among many of his other services. And he's going to share some of the arrangements, some of the concerns, how to stay clean, how to get started. You really want to listen to this. If you have you're thinking about these sorts of arrangements or you have them, this is going to be a very important episode for you to listen to. I'm Carl White, principal at Mark Advisory Group, which is a healthcare marketing agency, and I'm also the host of Practice Care. The mission for both is the same, and that's to help private practice owners stay private. It's usually what they want anyway, but care is better when the provider owns the practice because all the clinical decisions, all the business decisions are all looked at through one lens, which is patient first, patient best, business right along the way. But it's just easier when it's one person or one group making all the decisions. My guest today is E.J. Cyran. E.J. has spent over a decade as a healthcare attorney, which means he represents physicians, dentists, and their practices in negotiating all sorts of agreements, including arrangements with other healthcare providers, buying or selling their practice, handling associate buy-ins, and getting advice on their regulatory and payer issues. He knows his way around HIPAA, telehealth, Medicare, Medicaid, and all other matters affecting healthcare practices. He's definitely the go-to lawyer for his clients. E.J., welcome back. We've got quite the topic to tackle here on Practice Care
Thanks, Carl.
today.
It's great to be here.
Yeah. So before we jump into this very simple topic, help us get to know you a bit better. That's a short bio. That's what I asked for. Not everyone who listened to your first episode is going to listen to this one. We've got some newbies. Introduce yourself.
Absolutely. Thank you. E.J. Cyran, I'm a partner at Fox Rothschild in the Healthcare Practice Group. And what we do is we are business lawyers for healthcare providers. So think of maybe a corporate lawyer or an employment lawyer that you might have worked with before. We do that work, but we do it specifically for healthcare providers. And we add in all that expertise that is necessary for them from a healthcare regulatory standpoint and from an insurance reimbursement standpoint, because that is the source of their revenue in most cases. And there's so much that comes with that source of revenue, so different than other types of businesses. So we do all of those difficult to answer questions from a healthcare regulatory and payer perspective and the challenges with overpayment appeals and all those sorts of things. But we also help those healthcare providers with their employment agreements, with their M&A, with their vendor contracts, everything that comes up for them, because those healthcare laws and regulations, that insurance reimbursement real so often impact those legal documents.
Yeah, and every once in a while I get to remake the point of this is an area where specialization matters. There are lots of general attorneys, business attorneys out there who are very good at what they do. I've met one or two who said, yeah, I can do the healthcare stuff too. And I just say to myself, no, you can't. You just don't do that. Everything they can do, EJ can do. But if you're buying or selling a medical practice, that's different than buying or selling a manufacturing facility. There's different law that applies, different things to consider. This is not a fake it till you make it type of place to be. Find the healthcare attorney. Let's get into it. Arrangements with other healthcare providers for you as a private practice owner yourself. Start with some simple question. Give us some examples of what you mean by that so we can all understand what we're talking about.
Absolutely. Well, in the medical practice world, in private practice, you're always looking to grow your practice. You're looking to sustain it when there's attrition. And obviously some of that has to do simply with the quality of service you provide and the general marketing that you do. But it also has to do with your willingness to enter into arrangements with other healthcare provider types where appropriate for your specialty to provide additional services or provide those services in new venues. And when I say services, I also mean items, right? I mean devices and equipment for patients. These opportunities come up with other different providers from time to time, depending on the specialty. So I wanted to touch on a few that I see commonly. First, compounding pharmacies, right? So these are pharmacies that will compound drugs for your patients based on your prescription order for you to then dispense to the patient for their consumption
Hmm.
So this is common in medical practices that sway more toward the dietary or wellness clinics or nutrition based, or med spas, medi spas, as they're sometimes called,
Hmm.
that provide, cosmetic as well as wellness services for patients.
Hmm.
DME suppliers or durable medical equipment suppliers, these companies are often licensed themselves, not always, depending on the state, but they are the ones that distribute or dispense, if they're going to dispense directly to the patient, but to providers, they can distribute these medical devices or medical equipment that are necessary for the patient's health, orthopedic health, cardiovascular health, sometimes dermatologic or ophthalmologic. These things come up.
Hmm.
And so they're experts in that particular type of equipment, and they know how to service the patients with regard to that equipment.
Hmm.
So they can be very helpful to physicians who want to get involved with that equipment. They want to use it with their patients, but they maybe aren't familiar with it, or they don't have the administrative staff to handle the dispensing and
Or just the space,
maintaining it.
the processes. It could be, yeah, depending on what we're talking about, right?
And then you have inpatient facilities, a lot of different versions of this, right? Any type of facility where the patients are located, right? I'm being careful with what I'm saying there. Obviously, you could think of a hospital, which is
Sure.
a very heavily regulated healthcare facility.
Mhm.
You have skilled nursing facilities, you have behavioral health treatment facilities, you have assisted living facilities, which sometimes are licensed in a given state, sometimes they're not. But
Short-term rehab. Yeah.
yeah, your source of patients are there. They actually live there,
Hmm.
right? So it's very convenient for you and for the facility to have you come on site and provide your services to those patients. And that may involve just the patients that are already see in your practice, but that could also involve additional patients who see the convenience and want to receive your services at that facility.
Hmm.
It could also involve just leasing space there or leasing equipment from these facilities.
Hmm.
Another instance is where you as a physician are going to be a medical director. Maybe it's a
Mm.
dialysis center. Maybe it's for a home health agency, or an urgent care center, whatever it may be, where you're involved. Again, similar patients that are being serviced by these two providers, you
Hmm.
and the healthcare facility, and you guys are entering into an arrangement. It could be a wide variety of different arrangements, or it could be called a lot of different things.
Hmm.
But the bottom line is that these are two healthcare providers coming together, servicing the same patients, right? The same patient type, and they are entering into an arrangement that may involve one or more services, with the hopes that there's some benefit to the patient, but also a benefit to the providers here in entering into this arrangement.
And just to, I'm pretty sure the answer is yes, but in that last example where let's say you're a medical director somewhere else, you're not talking about being employed by that facility. You're talking about you have your own practice, and there's an arrangement where you come in and act that role.
Right. It's a part-time uh,
Correct.
occupation
Correct.
that you're doing you're filling a role for that particular facility. You have your own
Sure.
practice as well.
Sure. Okay. So at a high level, what does the law look for in these things? Federal point of view, state point of view, 50 states. Don't you have to go
Yeah,
state to state,
absolutely.
but yeah, let's start to
So
come down to the ground. We start at very high level.
yes, so what we're really looking for in these arrangements from a regulatory compliance perspective, et cetera, we're looking at federal law and whether it's applicable. We're looking at state laws, whether they're applicable, and we're looking at payer rules and your payer contracts to see what would apply to this scenario. Because at the end of the day, both of these providers are billing for services. And we're probably talking about a particular service that's going to be billed by one of the two providers
Mhm.
as a result of this arrangement. And the involvement of both of them is facilitating that service in some way, but it's only being billed by one, right? So it's almost always going to involve billing. And
Mhm.
therefore, we have to be concerned about federal and state healthcare laws and regulations and payer rules. But even if the arrangement didn't necessarily directly involve a particular service that was being billed, there could be referrals between the parties otherwise,
Hmm.
right? And so they're entering into a separate arrangement, just simply the leasing of some space, for example.
Okay.
But one of the parties refers patients to the other separately. They have been for years, right? And
Okay.
now they are entering into this new arrangement for a particular service that also implicates these laws and regulations and parables.
Okay. Any particular laws, like, imagine Medicare, Medicaid would have some things to say. Uh,
Yeah,
just going out
absolutely.
on a limb there.
Yeah, and well, it's the payer related laws and regulations, but it's also the licensure
Uh-huh.
laws and regulations for the physician,
Yeah.
for the other healthcare provider we're talking about,
Yeah.
right? They're licensed by the state to operate their facility.
Hmm.
There are a whole host of regulations that are going to be applicable to them,
Hmm.
right? And often physicians don't have any idea about those other licensure regulations. They might know their own,
Hmm.
for let's hope they know their own for medical licensure, but they probably don't know what the other facility situation is, or whether
Yeah.
that facility is even licensed necessarily,
Yeah.
right? So right, the first question then with this is what does federal law say on it? Does federal law apply at all? And when we're
Hmm.
talking about billing services, and we're talking about arrangements between healthcare providers, we're really talking about federal healthcare programs or
Hmm.
federally funded healthcare programs and the laws related to those. So
Okay.
Medicare, Medicaid. Medicaid is a joint program
Right.
between the federal
Federal
government
and
and
state.
each
Yeah.
state government. Um, and TRICARE is another common one for veterans that comes up. Sometimes the federal employee health benefit plan that might come up from time to time, especially in the DC metro area.
Hmm.
So under these payment programs,
Hmm.
the critical issues that come up are related to what's called the Stark Law, which is a anti-self-referral law or self-referral law, and the anti-kickback statute, the federal anti-kickback statute,
Hmm.
which would apply if it was a Medicare related service, a Medicaid related service, a TRICARE related service. If it's any federal healthcare program, the anti-kickback statute applies. But with Stark Law, it only applies in the Medicare setting. Um, Although there is some case law that kind of shifts a little bit into Medicaid, it's gone back and forth depending on the circuit, but mostly
Okay.
it's with respect to Medicare. And as I said, that's a self-referral law. It prohibits strictly any physician from referring certain specific types of services. There's a finite list. And if
Hmm.
you're not on that list, it doesn't apply. A lot of
Okay.
people get confused with that. They really get confused with that. It's those lists are called designated health services. They're actually published every year and
Okay.
updated every year by CMS, the Centers for Medicare and Medicaid Services. So examples are outpatient prescription drugs, so like that compound between pharmacy scenario, if it
Okay.
involves Medicare reimbursed drug, which
Yeah.
those actually often aren't in the wellness setting. Hospital services are designated health services, and certain types of durable medical equipment can be. So labs are also.
Oh, yeah.
So that's when you're in that world and you're talking about Medicare, then the Stark Law applies, and it has a strict liability law, and there are certain exceptions to that. In the anti-kickback world, right, under that anti-kickback statute and state anti-kickback statutes are similar, the question is not so much about what type of service, because as long as it's reimbursed by Medicare, Medicaid, TRICARE, if it was federal, um, or state Medicaid, then the statute applies. But it's not a strict liability law. It's based on quote intention. Did you intend to violate the law? But of course, the government has over the years developed a lot of cases where there's a lot of interpretation that is favorable to them. That do you really need to know the law to violate it? Right? Probably not.
Hmm.
Were you recklessly disregarding the law when you did this? Right? But the bottom line is, it's not a law that's strict liability. So when we don't say exceptions to the anti-kickback statute, we say safe harbors.
Hmm.
Safe harbors have been, set forth in the regulations, and if you meet that safe harbor, you can't be prosecuted for the arrangement. But those safe harbors have very specific criteria, and if you do
Sure.
not meet them exactly, then you aren't guaranteed protection from prosecution, right? So
I mean, I'm
safe
already
harbor.
getting the takeaway of, if I'm thinking of doing this, call number one is. Let me sit down with my healthcare attorney and just start to map it out. I mean,
Right. It
that's
gets
how my
very
brain, like, let's, rather than the self-inflicted, I told you so 6 months later, why don't I just try to get it
that's
right the first time?
and that comes up too often, right?
Yeah. Yeah. I mean,
Because
as you were talking about this, there's a referral relationship. There's, hey, let's kind of, I'll air quote this, get together and start generating patients together. I'm not even sure, but like, I imagine that there's, you know, referrals are good, generating's not, I'm not exactly sure, but can you like break that down? Because, the law is going to say what the law is going to say, but it depends on what's going on. And it sounds like this is a really important part of getting
that's
this right.
that's exactly right. Is what's going on between why are these parties getting together from a business perspective?
And why are
And
they doing it in this particular way? Right.
right,
Yeah.
right. And it obviously at the end of the day, it's coming down to money, right? And
Sure.
you've gotta, it's usually that the medical practice is approached by one of these other healthcare providers for this
Hmm.
arrangement. Or sometimes, although less common, the physician thinks, you know what, I'm sick and tired of having to deal with this particular supplier who doesn't do a great job of equipment, or I feel like I need to compound these drugs because I can make my money myself
Hmm.
if I do that and dispense it to the patient. And you know what, the stuff I'm doing with the compounding, what I'm asking for, it's really complicated. I want to be involved in that, whatever it may be. But they approach it in that way, and they start seeking this relationship with another healthcare provider, right? And that's the benefit that comes from that's what leads to the benefits that come from this arrangement, right?
Hmm.
So um, that benefit can be on both sides. It can be more on one side than the other, right? But the bottom line is they're coming together for a reason. So it could be as benign as, I have staff privileges at this hospital, and I see a lot of patients that I admit to this hospital. So why not have my medical office or one of my medical offices on campus at the hospital or in
Okay.
a medical office building, right? Why not do that? Because, maybe I cover call over at the hospital, but I'm often sending these people over there anyway.
Hmm.
Maybe there's a diagnostic imaging facility there. So it's not just admission to the hospital for inpatient care, but maybe they just need to go over there to get a lab work done or get an MRI or whatever it is.
Hmm.
It's easier and more convenient for my patients. Well, why don't I just go rent space there, right? It could be as benign as that,
Hmm.
but it could also be much more elaborate, like the DME supplier scenario or the compounding pharmacy scenario. We are going to come together. We're going to work to service this particular patient. We're going
Hmm.
to give them this drug. We're going to give them this equipment. We're going to give them this device. And we're going to make it easy on the physician because the physician has a lot of other things to worry about. In
Hmm.
addition to actually treating the patients and practicing medicine, they got
Hmm.
to manage their own practice, right?
Yeah. Yeah.
And so they don't have time to deal with equipment, maintaining it, dropping it off, picking it up, those kinds of things. Wow, you as a third party provider, you know how to do this as you specialize in this equipment, you specialize in this drug, you have the very expensive equipment to compound this drug.
Hmm.
You guys do it for me, and then I'll benefit as the physician, and I'll still be in control with my patients, right? So
Is
those are the
it
two.
worth like taking that example and you tell me, and like continuing down the path to say, as long as it looks like this, it's fine. But if they start to go in these other directions, they start to invite maybe some trouble.
I would say it's always something you need to have a knowledgeable healthcare lawyer review
Sure, to
you,
stay
because it's
fine.
just
Yes, but
people tend to discount what really matters with
mhm,
this, right? People tend to discount the business that's generated between them. Sometimes they'll say, "Well, I'm not really referring a patient. I'm not doing that. These patients, or the facility's not referring a patient to me. They
mhm,
aren't under their license saying that this patient needs a particular service, and here's the physician who's going to provide it. That's not what
mhm,
they're doing. But I happen to be, coming on site and have a temporary use of this particular office space or these exam rooms because this facility wants my patients to receive podiatry services, right, from me as a podiatrist, or cardiology services. They just have so many patients that need that service,
mhm.
and these patients aren't very mobile. They just want me to be able to provide those services to their patients. Are they really referring the patients to you? not in the way that a physician would normally think of it, right? So, or vice versa. Are you really referring these patients for services at the skilled nursing facility? Probably not, right? But that doesn't mean that there aren't there aren't patients who are coming to you, right, and who are receiving services that are then being billed to Medicare, Medicaid, workers'
Hmm.
compensation, commercial insurance, whatever it may be,
Right.
as a result of this arrangement, and therefore it gets pulled in. You can think of it almost as a fruit of the poisonous tree, right? It gets pulled in to these regulatory schemes almost unknowingly, right? Because it's not your standard, if you refer me a patient, I'll pay you. It's not a standard kickback scenario,
Right.
right? In the physician's mind. And so if it's not that, it's fine, is what a lot of people think. So yeah,
Yeah.
it's definitely something that you want to have looked at whenever there's an arrangement for anything between two healthcare providers.
So if a podiatrist goes in once a week to a skilled nursing facility to treat patients who may need foot care, um, there's more to think about than just, and then the podiatrist bills for their,
Right.
every appointment as if that patient had gone to their office instead. So that's okay, could be okay. Like if that's a good example to say, as long as they do it this way, not all the nuance and detail, they're fine. But if they start to do blah, that's when is that even an appropriate way to think about it?
No, I think it's too minimalistic and simplistic.
Okay. Well, I try to do that here on Practice Care.
Podiatry typically involves Medicare patients.
Mhm.
Most patients that
Yeah.
have the issues with diabetes and wound care and everything else that relate to the feet, they are Medicare patients, and so they're over 65, right? So the just the fact that Medicare is the payer already implicates these schemes. Now, again, is it a violation? No, it isn't necessarily a violation. It
Hmm.
could be. And
Hmm.
that's all going to be based on business matters, right? How much is being paid for this space? What other arrangements might these two parties have together, which is often
Hmm.
overlooked? You know, um, it could be a variety of benefits that one gets or the other gets, and they don't really realize it at first blush, right? But they
Hmm.
need to talk with knowledgeable attorney about these things to work through it. And then we can absolutely structure it in a way that is compliant.
Hmm.
Or we might have to say, you know what, you got to drop that part of it because there's no way it's going to work,
Got
right?
it.
But you can still have an arrangement with them and sort of get to that same point. And that's
Hmm.
one thing I wanted to note is, my job as I said it before, I'm a business lawyer for healthcare providers. I'm not just a specialist you come to when you got an arcane question.
Hmm.
I'm trying to find resolutions,
Hmm.
solutions for these issues, hopefully resolutions if it's an issue that already happened, solution for a proposed
Yeah.
arrangement, right?
Yeah.
Where both parties still get what they're really trying to get out of this, right? But it's compliant.
Yeah. Right. 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 Okay. Um, Another facet, it almost sounded like you were going down this path too. Services provided back and forth. So more than one with the same patient, which is expand on that, what that means, why
Right.
that's,
So
yeah.
sometimes it's one way, right? Sometimes,
So the podiatry example, would that be an example of one way or no?
well, yeah, I mean, obviously the patients are receiving services.
Yes.
But between the parties in that arrangement, there's something that the podiatry practice is receiving the space for a certain period of time
Right. Okay.
every week, right?
Hmm.
The facility is receiving not really a service, but it's receiving a benefit in the sense that these patients have a convenience, right? And they're going to be overall healthier
Hmm.
in the long run if they need podiatry services and they can just go downstairs
Right.
on that certain day to go get them,
Yes.
right?
Yes.
Now, is that a impermissible benefit? Is that a benefit that would potentially implicate the anti-kickback statute? Not necessarily,
Hmm.
right? Not necessarily, but certainly the space being provided is a clear one that would implicate the anti-kickback statute. When I say implicate, I just simply mean that it would apply, not that it necessarily would be violated.
So the
Because for
podiatrist
example,
should
yeah,
pay an appropriate rent for that space. Is that what you mean?
well, right. So then we get it. That's right. That's the
If I'm
next
getting
part of it.
ahead, forget it. So just tell, yeah,
Yeah,
but
yeah. Well, no, it's a good point though, and we should transition into that. Is these services that are being provided, some money is probably exchanging hands, right?
Mm-hmm.
Otherwise, why is the other healthcare providing this?
Yeah.
Healthcare provider providing this, right? So there's somebody's getting something very tangible, very clear from this.
Mm-hmm.
The point to remember with the services is that sometimes the other party is getting something in return as well.
Mm-hmm.
That's not monetary, or it's more benign. It's harder to see, and that may be problematic. It may not, but it needs to be looked at.
Mm-hmm.
That's the point, right? So yes, the question is, well then, how do you make this arrangement compliant, or what are the things to look out for when you're making this relationship compliant?
Right.
The number one thing is fair market value for whatever items, services are being provided. Items,
Mm-hmm.
so think about the equipment scenario we were talking about, where they're being leased or they're being sold to the physician, and he gets to then easily dispense it to the patient. Why? Because that supplier is going to drop ship it, right? And then they're going to go pick it up if it needs to be picked up because it was leased, and maintain it, clean it up, and give it back to the physician for use with the next patient, right?
Mm-hmm.
Like, what is the fair market value for the services that are being provided, the items that are being received, right? The rent. What's the fair market value for that? Why do we say fair market value? Because at the core of the Stark Law or the anti-kickback statute at the federal level or state level, or other state laws and regulations, which could be generic kickback laws, right, or regulations related to the physician or the facility, right? As in the licensure regulations, like we were mentioning, there could be, if that facility gets a referral and pays for it, it's a kickback violation regardless of the payer who actually reimburses it, because it's at the state level, right? It could be payer related. They are in an arrangement where there could be regulations that people don't expect that apply. So another one that comes up is called fee splitting regulations in that category.
Okay.
What the heck is fee splitting, right?
Yeah.
Well, because it's written like, a physician can't share the revenue for professional services that he or she provides with anyone else who's not a physician. Well, how do they pay their rent, right?
Yeah.
Well, so it doesn't mean that. It means you can't share additional, right, above fair market value revenue. You can't pay more than fair market value for the service, because then you'd be sharing that additional amount of revenue with them.
Just by definition, if more is coming in than ought to be, we're going to call it sharing, and that's bad.
Right, exactly.
Yeah. Okay.
So the fair market value is at the heart of all this, because you should be able to, as a physician, pay for services that you receive, right? But you can't go over that amount, right? Or you can't go under that amount if there's a benefit, if the other healthcare provider is the one that it applies to, right? And so that also gets confusing very quickly. So fair market value is not a specific number. People get confused with that too, right? It's not $100,000 per year, or $10,000 per month. No, it's a range that depends on the actual. It depends on the actual services that we're talking about, or the items we're talking about, and different approaches to valuing it.
And the part of the country. I mean, right. It's probably
region.
Yeah.
Who does that valuation?
Right.
Not an attorney.
Right.
It's a healthcare valuation expert. And this is not a business valuation expert. It's not an M&A valuation expert. It is a healthcare valuation expert. Now, sometimes those experts also do M&A valuations, but it cannot be just some business valuation firm. It needs to be a healthcare valuation firm. Why? They need to understand these laws I'm talking about, which they all do as healthcare valuation experts. And they need to understand services, equipment, items, rent in the healthcare industry, right? So what they will do is they'll complete a whole report, and they will talk about the different approaches that are customary to use. One of them is the cost-based approach, another is the income-based approach, another is the market-based approach. They will explain all that as appropriate. Sometimes one of those approaches isn't appropriate for what we're talking about. They explain all that, and then you have a document that you can rely upon if you're ever scrutinized by a federal government, state government, payer, whatever it may be, to to explain
Yeah.
and support the amount that you paid for this arrangement. And it shows the legitimacy of the arrangement to a
Yeah.
degree, right? That you took the time and you paid the money to have somebody actually value this. And in addition, you also had the agreement negotiated. You can point to the contract and what that says, right?
Yeah.
So fair market value is at the center of the compliance.
Mhm.
But it also goes back to what we're talking about with the services that are being provided, really understanding that,
Mhm.
right? And being clear about the legitimate services, as
Yeah.
I say, but like what it is that you're really getting that's tangible, and not going overboard with talking about things that may be intangible, but really aren't going to be of concern. So let's not draw attention to them, right?
Mhm.
So that can get nuanced very quickly depending on the rule, regulation we're talking about.
Sure, of
But
course.
there are a lot of different aspects to that.
Yeah. And I totally get the need to go with fair market value. It's just as you're describing all this process, I'm thinking to myself, the fair market value of a box of Cheerios, is whatever the price is at the grocery store. It's so easy, right? And this is just seems like it's too bad that this is what we have to get to. But I think generally as fair market value is it's what you be willing to accept to do the right thing, to do the clinically appropriate thing, and if it's any less than that or any more than that, it's why is that,
Right.
and that's a bad why. You don't want to be asked why in that context because it doesn't have anything to do with the patient. It has something to do with something else. And if the fair market value isn't good enough, well, then maybe you shouldn't be doing that. I mean, this is very easy to say, but fair market value is a huge cut. So we covered a lot here. We have some examples. We talked about referrals versus sort of generating business, fair market value, services back and forth, federal, state. Did we miss anything? I mean, right, we could do a year on this, but I mean, in the context, we covered and is there anything you think we really should have covered, we just didn't get to?
Yeah, a couple of things. First of all, this is becoming more and more popular over the last decade, and I think that it's the future of healthcare in another number of different specialties.
Mhm.
Whether we're talking about certain facilities, we're talking about certain types of medical specialties. Value-based arrangements are a way to comply with these difficult to comply with laws,
Mhm.
like the Stark Law and like the anti-kickback statutes,
Mhm.
fee splitting rules. They can bypass those if they are endowed by law to do that, depending on the state or if it's a federal law, the
Mhm.
U.S. government and Congress and how they've designed this. But
Mhm.
these, if they meet certain criteria, they allow you to effectively enter into these arrangements without being that concerned about the fact that there are referrals, that there are patients that are being recommended, that it's resulting in an increase in billables, right,
Mhm.
for one or both providers.
Mhm.
Those you have to meet the criteria. They continue to be developed on an annual basis.
It's a very
It's
diplomatic way of saying it.
yeah. And again, it really applies more to certain specialties than others, but I do think it will expand over time. So, knowledgeable healthcare lawyer can help the medical practice and facility look into those kinds of arrangements.
Yeah.
And then that contract's going to look different as a result. But it really does, it provides relief for my clients that have those arrangements that, what, we got past all that compliance. We're not going to have to worry about this again. We're going to refer to each other. It's going to be for the benefit of the patient, right? That's the value-based element.
Yeah.
And it saves on utilization, avoids overutilization. It saves on costs for the payers, which is why, Medicare or Medicaid may like it. And actually commercial insurers are getting more and more interested in it too, right? And they will be a part of this value-based arrangement that we're
Mhm.
talking about. It have to be
Mhm.
specific, right? That they would jump into this, but they want to save money on cancer care, for
Sure.
example, chemotherapy. So let's enter an arrangement for using more generic drugs, for
Mhm.
example, right?
Mhm.
So those things can come up and they will more and more. So that's one thing to keep in mind. And then the other is hospital arrangements of any type are fraught with peril. So, if
The
you're
hospital is just a different animal.
yeah, if you're going to lease space for them in a medical office building, or if you're going to be a medical director, or if you're going to, um, enter into a co-management arrangement for their oncology center, whatever it may be. You're doing something additional than your standard private practice over here, hospital over here, and from time to time you have to refer your patients to the hospital. If you're doing anything other than that, because there's some other contract in place or there's some other arrangement in place, those really need to be scrutinized because they often involve high volume, right? And then they also involve expensive services, right? So they are more likely to end up, being scrutinized and resulting in significant losses,
Yeah.
penalties, interest, etc., overpayments, right, with the payers if they are non-compliant.
Right. Okay. So the hospital's a different beast, which is not a surprising thing to hear in a generalized sense.
Right.
So the other question, that was the first question I asked to sort of wrap up an episode. The second one is we've caught a listener's attention and it's not so much, they want to get started doing this, but I think they're wondering about, I think but how can they get started is the question for any regular listener. I kind of want to answer it. One of them is, I don't see any way around finding a healthcare attorney or contacting one if you haven't used one. It's just too much. This isn't a simple thing.
Right.
I just don't see any way around it. And EJ, we've got your contact info in the show notes, so you're certainly a resource. One question I wanted to ask you, though, let's say you've got one of these arrangements in place. Should these things be reviewed from time to time? Like, I don't know, every other year, we should just make sure we're still compliant
Yeah, I
because
mean, fair market value
there you
is stuck
go.
at a point
Just
in
that
time.
alone, right? I mean,
Right.
yeah.
And so these contracts need to provide for that fair market value to be updated from time to time. That if there's a change in law, meaning also regulations, like is there anything
Yeah.
from a legal perspective that's changed with respect to this arrangement? Either party can, upon notice to the other, you know, uh, explain that and
Mm-hmm.
enter into negotiations in good faith to fix
Mm-hmm.
the arrangement so that it now is compliant.
Mm-hmm.
Those provisions are critical because otherwise the only option would be, both parties actually agree that that particular change in law or that the fair market value actually needed to be changed, in which case both parties to a contract can always agree to change something. That's
Yeah.
not a problem. The
Yeah.
problem comes up when one of them doesn't want to change it
Right.
because they're benefiting from the status quo. And now the other party is more at risk, or their legal advisors believe they're more at risk. And the only thing they can do is threaten to end the relationship through
Mm-hmm.
without cause termination. Say, all right, we're going to part ways in 90 days or 180 days, whatever that term may be.
Mm-hmm.
In the meantime, they're exposed, right?
Mm-hmm.
And there are a lot of overpayments that could be possible from those services that are
Mm.
billed, right? So it's an important provision to have in those contracts. It's sort of a safety valve when
Yeah.
these things change.
Yeah.
Um, but also, it's important to recognize when maybe the arrangement between the parties just changes because now they're doing other things together unrelated
Things
to
change. Yeah.
right. And
Yeah.
if that happens, a knowledgeable attorney is going to say, we need to go back to that arrangement now, and we need to readdress that situation because now you're referring to this supplier separately, and that supplier is dispensing, they're dispensing to Medicare patients, but then they were also helping you over here with workers' comp.
Mm-hmm.
And the way that the Office of Inspector General at the U.S. level has interpreted the anti-kickback statute, indirect relationships like that, where there's value being exchanged somewhere else, are violating the statute
Mm-hmm.
if the criteria are met in another arrangement.
Yeah.
That's the problem. So you can't, it's not just simply, well, that's something else between
Yeah.
us. This is something discrete. No, they're not independent. They are considered dependent upon one another because there's benefits going and referrals going in both directions or one way or whatever it is. And it's indirect,
Yeah.
okay? Direct or indirect. So yeah, all those scenarios can come up and are important to address in the future.
So then maybe the best move is you should have a regular meeting with your healthcare attorney, whatever the right cadence is. How's business? What's new? Who you working with? I don't know what the scrutiny needs to look like, but you spend a lot of time setting up an arrangement. Um, it's not etched in stone, right? I mean, business grows, situations change, regulation. For all the hard work you put in to set it up, um, you got to keep it kosher too, right? I mean, you change the oil in your car, you got to
Exactly.
change it again. There's maintenance. There's maintenance on
And
these things.
that's
Think
right,
of it
Carl. And
that
that's
way.
that's
Yeah.
why we are that full service shop, right? We do all of the legal services, provide all the legal advice, draft all the contracts, negotiate all the deals for these providers, because we want them to be coming to us so that we are aware of everything that they're doing,
Hmm.
right? And they want to be coming to us because then they're only dealing with one lawyer who understands the nuances of all of their business and
Hmm.
how one discrete scenario might actually impact other things,
Hmm.
right? You just don't get that if you've got your healthcare specialist and you've got your employment lawyer and you've got your, general corporate lawyer or business lawyer. These things get confused and
Hmm.
nobody talks to the other because it would
Hmm.
cost money to you, the physician,
Right.
if you had them do
And
that.
nobody's even aware. You
Right.
know what? I got to call
Yeah.
that employment. Probably it doesn't even occur to people enough times, let alone it's
Right.
actually done. Yeah. Yeah. Excellent. Man, oh man, we covered a lot of ground.
You
At least
did.
it feels like we covered a lot of ground. The takeaway for me is um, do these things as long as the patient, but if you can't say how the patient's going to benefit first, then you should just stop. But if you could say, there's a real patient
Yeah.
benefit both in clinical outcomes and convenience, and we're thinking about a fair price, keep going, keep going, but don't do it alone. So we covered a lot of ground. Thank you so much for doing that, for taking time to explain this to us. Um, if you're like
My
me, you're a bit
pleasure.
more confused now, but that's a good thing. That's part of the process. That's
That's
part of the
right.
process, especially with
There
with
is a
legal matters.
solution.
There is a solution. Your contact information, like I said, is going to be in the show notes for this episode. So anyone who wants to contact you now, they have another way to do it. But thank you for coming on again. I really, really appreciate it.
My pleasure, Carl. It's great to be
Two,
here.
yeah, 2 points. First, subscribe to Practice Care, please. Practice Care is one word if you haven't done it yet, because this is the only way to stay up to date with new episodes, which we drop every week. We're on Apple, Spotify, YouTube, any player that you have. We're easy to find. Practice Care is one word. And finally, if you're someone like EJ or I, you serve private practice care owners, or you're a private practice owner yourself, and you've got experience on the business side, whatever it is, the business side is vast. Don't worry if you're not sure of a topic. We'll figure it out. Your colleagues can benefit from your experience. So please tell us about it in the show notes for EJ's episode. And every episode, there's a link. Take you 2 minutes. Just tell us what's on your mind and we'll get you scheduled as soon as possible. Thanks very much. And until next time.